Hey, I'm Dr. Silva. Welcome to the Protriptyline video. This is a video about Protriptyline, a tricyclic agent, one of the members of the class of antidepressant agents that were the first generation antidepressants. If you want an overview of all of the tricyclics, please check out my video on the TCAs. But Protriptyline is a medication like the other tricyclic agents. It's an SNRI, a serotonin norepinephrine reuptake inhibitor. And it is more noradrenergic, i.e. it blocks the reuptake of norepinephrine more than serotonin. And so it's more of an NRI than an SRI. And that's true of most of the tricyclic agents. But by blocking the reuptake of these neurotransmitters at the synapse, at the juncture between neurons where the neurons communicate, the medications increase the concentrations of these neurotransmitters at those junctures, and therefore they increase the actions of those neurotransmitters with specific psychotropic and also other physiologic effects. And I'll go into side effects in just a little bit. But serotonin and norepinephrine have differential actions. Serotonin is a soothing, calming neurotransmitter. You increase the levels of serotonin, people become less anxious, they become less tearful, less irritable, generally less agitated in their dysphoria. But it's not good for improving energy or cognition or initiative or the libido. In fact, it diminishes all of those things. It can cause anhedonia, and it can cause lethargy and even sedation. Norepinephrine, on the other hand, noradrenaline is the brand name, is, as we all know, adrenaline and noradrenaline. They come from the adrenal glands. The hormones are released in the adrenal glands, but when they're released in the central nervous system, they're neurotransmitters, they're acting as neurotransmitters. But the effects in the brain, in the central nervous system, are the opposite of serotonin. So you get improved initiative, you get an increase in reactivity. Patients can actually become reactionary, they can become irritable. And because blocking the reuptake of norepinephrine increases dopamine, which is another monoamine neurotransmitter, in the prefrontal cortex, and that has to do with the anatomy in the prefrontal cortex. There are no dopamine reuptake pumps, so if you block the reuptake of norepinephrine in that region of the brain, you increase not only norepinephrine, but also dopamine. And that definitely increases the sex drive, cognition, and again, just feeling like doing things and taking pleasure in doing things. The opposite of anhedonia. So the SNRIs, the tricyclic agents, the TCAs, TCA SNRIs, first generation SNRIs, where venlafaxine, Effexor, and duloxetine Cymbalta were the second generation, more modern SNRIs. The TCAs increase really all three monoamine neurotransmitters, but dopamine only in the prefrontal cortex. And because you don't get increased dopamine in the limbic system, for example, you don't get the addictive potential. You don't get euphoria like you do with the stimulants. But because you do increase dopamine in the prefrontal cortex, it can be good for attention and concentration, and so it can be used, this class of medications can be used off-label for the treatment of attention deficit disorder, and in particular, Protriptyline as being one of the more noradrenergic agents, as opposed to clomipramine and imipramine, which are the more serotonergic agents. But the most noradrenergic agents are actually nortriptyline and desipramine. Those are other videos. Anyway, that's sort of an overview of what they do. The TCAs are all FDA approved for depression, and in particular, Protriptyline is approved for quote-unquote mental depression. And it's interesting because these medications are so archaic, they're so first generation, that the indications don't match the DSM-5, the 5th edition of the Diagnostic and Statistical Manual. Mental depression isn't even a term anymore. I don't know what that is. That really isn't anything anymore. There's major depression, and then there are other forms of depression, dysthymia, adjustment disorders with depression, and medication-induced depression, and depression due to hypothyroidism, and there's lots of kinds of depression. But mental depression, that sounds like it's suggestive of a psychological depression, more of a reactionary depression, maybe what we would call today an adjustment disorder with depression, because it's more exogenous than endogenous. Back in the day of the DSM-1 and 2, there was a lot more emphasis on psychodynamics and the psychosocial variables because we didn't have very many medications. As a matter of fact, the tricyclic class, being the first generation of antidepressants, were the medications that helped to herald the new age, the modern age of psychiatry, in which we changed the nosology based on the biochemistry and based on treating with psychopharmacology. And so, at any rate, these medications, though, they're used off-label quite a bit, and they're very effective. We wouldn't use them off-label if they weren't effective. Off-label meaning not FDA approved for anxiety. And because most of them are more noradrenergic than serotonergic, they're not perhaps as good for anxiety as the SSRIs, because except for clomipramine and imipramine, they're more noradrenergic. They increase norepinephrine and dopamine in the prefrontal cortex more so. But they're still good for anxiety, and they are good for insomnia because they're sedating, and that's mediated by their antihistaminergic effects. They're all antihistamines as well. The problem with the first generation agents is that they're so-called dirty drugs. They hit a lot of receptors. They're not just serotonin norepinephrine reuptake inhibitors. They're also antihistamines, rather significant antihistamines. Doxepin is very potent antihistamine, even at very low doses. And they are anticholinergic medications. They block muscarinic acetylcholine receptors. They also block presynaptic alpha-1 adrenergic receptors, and that leads to postural hypotension, which I'll talk about in a little bit. So they're dirty drugs that in overdose are fatal because they can also cause cardiac conduction abnormalities by, we think, inhibiting the flux of ions, and that can affect the heart, and they can prolong the QT interval, which is the length of the heartbeat. So they're not good in patients with a slow heartbeat, and they're not good in patients with arrhythmias. The advantage of venlafaxine and duloxetine is that they're SNRIs, but they're selective for serotonin and norepinephrine. As a matter of fact, that's why when they developed the SSRIs, they called them selective serotonin reuptake inhibitors because they were so selective. Selectivity was fairly novel. The tricyclics are also very good for neuropathic pain. That is pain that is caused due to neuropathy. Diabetic is probably the most common, but you can also damage, especially the small nerves, if you have chronic hypertension, high blood pressure. There are autoimmune diseases that can attack the nervous system. So when the nerves themselves are damaged and the pain is coming not from end organs that have been traumatized or that are diseased, but from the nervous system itself, and medications like Lyrica and gabapentin are used to treat those, and the tricyclics are also off-label medications that are very effective. They also prevent migraine headaches. The unique thing about protriptyline is that, first of all, it is dosed rather low dosing range, 15 to 40 milligrams, with the accepted maximum being 60 milligrams. Whereas the other tricyclic agents range from 75 milligrams to 300 milligrams maximum. And also you have to dose protriptyline 3 to 4 times a day. So that's probably why it wasn't used very much, because it's very inconvenient dosing. It's hard enough to remember to take your medication twice a day, 3 times a day, and the percentage of patients who are able to comply with that on a regular basis really dwindles. You increase that to 4 times a day, and you're really asking for it. Non-compliance, non-adherence. But because you have to dose it so frequently, you do have to obviously dose it during the day. Fortunately, protriptyline appears to be less sedating than the other tricyclic agents, and in fact could actually be activating. It actually may be a niche tricyclic agent for patients that are anergic, that have low energy, and that just feel lethargic and sort of heavy, not because of side effects of medication, but because they are depressed and their depression is manifesting as low energy. It's not clear to me, this is a mystery, I've researched this, but the half-life of protriptyline is 74 hours approximately. The half-life is the length of time that it takes the body to clear 50% of the medication for a given dosage. So 5 half-lives, and you've got 98% of the medication cleared. So it takes 5 half-lives both to get to steady state, as long as you're dosing in less than 1 half-life intervals, and it takes 5 half-lives to clear the medicine. I don't understand why you have to dose protriptyline 3 or 4 times a day. If the half-life is 74 hours, you should be able to dose it once every 3 days with those numbers. But I'm sure it has to do with the pharmacokinetics. Side effects. Well, first of all, the nonspecifics. Nausea. Any medication can cause nausea. Headaches. Diarrhea. Dizziness. Fatigue. Those are non-specific side effects. A big one, though, is sedation. And we think this is mediated by these medications' antihistaminergic effects. So they're essentially antihistamines. And so they block the H1 type of histamine receptor, the type that's involved in seasonal allergies, not the type that's involved in your stomach acid. We're talking about blocking the H1 receptors. They are found in the central nervous system, and they result in sedation, which can be very significant. Mirtazapine is a tetracyclic, a little bit more modern antidepressant that's used a lot, and it too creates sedation through its antihistamine effect. Weight gain is another real problem with these agents. They increase the appetite. They don't change the metabolism. They increase the appetite, especially for carbohydrates. For some reason, you're not going to crave broccoli, but the pastas and the sugary sweet foods, you're really going to want those more, and you're going to gain weight from that, and it could cause metabolic syndrome. Type 2 diabetes, hypercholesterolemia, elevated cholesterol, as well as a bad ratio of the quote-unquote good cholesterol to the bad cholesterol, dyslipidemia. You really do have to weigh patients at baseline and monitor them very carefully. That's a huge drawback and a deal breaker for a lot of patients. They also, all of them, to some extent or another, block muscarinic acetylcholine receptors. So they're anticholinergic, and you get all of the side effects that go with that, from dry mouth to constipation. To urinary retention, to blurred vision. Blurred vision because it impairs accommodation. So you get blurred near vision. The pupils can't accommodate. Protriptyline may be more anticholinergic than some of the other tricyclic agents. It's not the most anticholinergic. That prize goes to amitriptyline. But because of the anticholinergic effects, you really have to worry more about paralytic ileus, especially in combination with other anticholinergic medications. And it's also been found to maybe have a little bit more postural hypotension, and the tachycardia that results from both of those conditions can be problematic, particularly in patients with compromised cardiac function as it is. All of these medications can cause sexual dysfunction, mostly anorgasmia and a lowered libido because of the serotonergic actions, but you can also get erectile dysfunction. That could be a consequence of a low libido, but it could also be a direct effect of norepinephrine, which inhibits the parasympathetic nervous system and interferes with the erection. In a lot of men, particularly men that are middle-aged, they might have other risk factors like cardiovascular disease, chronic hypertension, etc. Orthostasis, orthostatic hypotension, is a loss of blood pressure, a drop in blood pressure in the cranium upon standing. Ortho means upright, erect, stasis, to stand. And so when you get up, especially if you've been lying down or even sitting down, and you come to a standing position, the blood pools due to gravity, and your vasculature is supposed to compensate by constricting to maintain pressure, but you get interference with that system with these medications, and that can lead to dizziness and even fainting and falling. We do see severe hypotension in overdose. You want to get a baseline EKG in your patients that are older than 50, because these agents can also cause QTC prolongation. QTC stands for the corrected QT interval, and that refers to the electrocardiogram, the QRST complex, which measures in milliseconds the length of a heartbeat. So in patients who already have varying degrees of heart block, you want to avoid using tricyclic agents, or in patients that already have arrhythmias, because prolongation of the QTC could lead to fatal arrhythmia, a torsade de points, which looks like this and looks like this. Again, these medications are fatal in overdose. You see seizures, arrhythmias, fatal arrhythmias, coma, and death. Definitely not a good choice for patients that are chronically suicidal or patients who are prone to overdose. Other side effects include sweating, increased sweating, because you have the increased norepinephrine, and so upon exertion. But also you could, in theory, have hot flashes as well, temperature dysregulation. That's due to increased serotonin. I have another video, it's an instant replay on sweating, on drug-induced sweating, so you can check that out for more information. Heartburn has been reported, a weird taste in the mouth, that can happen. These are not as common. Akathisia, which is a motor restlessness, a fidgetiness, a need to move and feeling very uncomfortable if you can't move. In the extreme, it takes the form of pacing, but probably more commonly you would see fidgeting, squirming, inability to stay seated, maybe a bouncing knee or a tapping toe. That's called akathisia, and it's due to increased serotonin, which is antagonizing dopamine in certain regions of the brain. You can also see rarely the induction of mania in those individuals who are susceptible to it. So patients with bipolar spectrum illness, you're not going to see mania in patients that aren't prone to manic episodes. Even in overdose, you're not going to see mania unless you have a person who's bipolar. And similarly, patients that are vulnerable to psychosis would be at increased risk, theoretically, but this is rare. Controversial side effect would be suicidal ideations. Any antidepressant, in theory, especially in young, impulsive people, could, in theory, increase suicidal ideations and even behaviors. This is controversial. It's not really been proven. I am on the side of there's really very little proof of that, and I certainly don't worry about it in really any of my patients. Definitely not in patients that are older. But I warn all patients about it. I ask all patients about suicidality, whether they've had problems with depression or not. And I do caution them that if they start to have thoughts, weird thoughts, to let me know. In a young, impulsive patient, you really do have to be careful about that. The other thing about protriptyline is that it may be faster than some of the other agents. There are reports that it can maybe start to work as fast as 1 week, which it's interesting because that's also been said both of venlafaxine Effexor and duloxetine Cymbalta, which are also SNRIs. It may not be something particular to tricyclic agents, but typically for endogenous major depression and anxiety states especially, you have to wait anywhere from 2 to 4 weeks. And for anxiety, 6 to 8 to 12 weeks for full remission. Other considerations, there are drug-drug interactions, and because these medications can be fatal, you really have to watch combining them with other agents that may increase the blood levels of these medications. That is to say, medications that inhibit the metabolism of the tricyclics and would, for example, prolong the QT interval. Medications like the first-generation antipsychotic, also mood stabilizer, thioridazine, Mellaril, as well as Pimozide, Orap, and that one was approved for tic disorder. It was used in children for Tourette's as well. They're not used very much anymore because these are dinosaurs, but there are also certain antibiotics and antiarrhythmic agents which prolong the QT interval. And again, if you've already got somebody who's bradycardic or who's on a beta blocker for hypertension or some other condition that's already slowing the heart rate, you probably aren't going to want to combine with a tricyclic agent. And anyone over the age of 50, you have to get an EKG. That's the standard of care. So in the elderly, I would definitely shy away from the tricyclics, and just about anybody with significant cardiac disease, because you could get a fatal arrhythmia and it can cause death. You also want to be very careful combining the tricyclic agents with other agents that are anticholinergic. In the worst case scenario, you could get a paralytic ileus, where your constipation is a side effect, but you could actually shut down the bowels completely, especially in the elderly, and that can be deadly. And hyperthermia and delirium and death are possible just from anticholinergic toxicity. There are also drug-drug interactions that have to do with the cytochrome P450 enzyme system in the liver, so any medication that inhibits the 2D6 enzyme, such as Prozac and Paxil and Wellbutrin and Cymbalta, just to name a few, those would inhibit the metabolism of protriptyline and the other tricyclic agents, most of the other ones, and that would increase their levels, and that would increase their side effects and their potential toxicity. And it's also worth noting that methylphenidate might inhibit the metabolism of tricyclic agents as well. So you want to be careful combining it with methylphenidate, and you also want to be careful combining with the opiate pain medication tramadol. For a lot of reasons, tramadol is also a serotonin norepinephrine reuptake inhibitor, so it could cause serotonin syndrome, not so much in conjunction with protriptyline, because protriptyline it's not very highly serotonergic. I'm not going to say it's negligible. At high enough doses, if you were at 60 or above, and particularly in an elderly person who was also on a very high dose of an SSRI or, God forbid, an MAOI, a monoamine oxidase inhibitor, you could absolutely induce serotonin syndrome. And tramadol also would decrease gastrointestinal motility, so you would have that double whammy situation. And protriptyline also is thought maybe to cause a little bit more hypotension, more postural hypotension, orthostatic hypotension, which would lead to tachycardia. And anticholinergic side effects also include tachycardia, because if you inhibit the action of acetylcholine on the vagus nerve, that will increase the heart rate. It kind of takes the brake off of the innervation to the heart that controls the speed of the heart. So that's enough said about protriptyline. It's a medication that is probably not many people are searching for it on YouTube because it's hardly prescribed anymore, really. Pharmacy would probably have to special order it. It used to be called Vivactil, but it's been generic for eons. Thank you for listening.